Hi, everyone. My name is Nishant Shah. I am an anesthesiologist in Chicago in private practice, and today I will be giving a presentation on the Transversus Abdominis Plane block presented to you by Sonocyte. As I mentioned, we normally call it the TAP block, and the exact uh, translation of that is the Transversus Abdominis Plane block, which is a muscle in the abdomen, which we will go over in much detail in just a little bit. First, here's a disclosure, just to make sure that everyone knows this is not a complete description of the block and a complete course, but it will provide you with the tools necessary to start on your path to providing what the block provides. So I wanted to start with a little bit of a historical perspective. Abdominal field blocks were performed for many years, but with limited success. And as a result, the analgesic area was very limited because the success was variable. It required multiple injections and injection sites. As you can imagine, without the benefit of an ultrasound, a lot of it had to be a little bit of guesswork, a little bit of landmark based work, but all in all, it ended up having multiple injections and multiple sites. Also, one kind of unhappy consequence of not knowing exactly where you needed to go was very large volumes of local anesthetic were used. We're going to go into the detail about the volumes of local anesthetic a little bit in the future of this presentation, but what I wanted to make sure that everyone understands is ultrasound has allowed us to decrease the amount of volume of local anesthetic, which is obviously safer. The endpoint for the success for this block was something called the POP method, which I'm not a fan of at all. What it was is you were supposed to feel for 2 pops, and that would guarantee that you were in the right muscle plane. As I'm sure many of you realize, all patients are made differently. All of them have different levels of adipose tissue and fascial tissue, and everybody is made a little bit different. So, to relegate everyone to performing this block by feeling for 2 pops is kind of a method which doesn't provide much success because it's a very variable thing. Currently, the new perspective of transversus abdominis plane blocks is one of much success because we have ultrasound visualization, which allows very, very exact deposition of the local anesthetic into the correct plane. As a result, it eliminates any guesswork, and we have reliable spread, which then results in good coverage and good analgesia. It also, as I mentioned, decreases the amount of local anesthetic, which then has the happy byproduct of decreasing the amount of or the probability of local anesthetic toxicity. When performing a tap block, the first and foremost thing that's very important is understanding the anatomy. If one can understand the anatomy, then no matter how skinny or obese the patient is, no matter how difficult or simple the block may be, one is able to navigate their way through, and the ability to perform a successful block goes up exponentially. So, the objective when performing the tap block is to help relieve pain in the anterolateral abdominal wall. And that's kind of the overhanging theme and why we would ever perform this block. And so the innervation of this anterolateral abdominal wall arises from the anterior rami of T7 to L1. When you specifically break down to break down the anterior rami, you have the intercostal nerves, which are composed of T7 to T11, and then you have the subcostal nerve, which is T12, and then the iliohypogastric and the ilioinguinal nerves, which are provided by L1. Before we go on to how to perform this block, I think it's very important to understand why we would perform this block. And so there are many indications, and those are simple things such as appendectomies and hernia repairs like ventral, umbilical, and inguinal repairs, but also bigger operations such as laparotomies, abdominoplasties, hysterectomies, even laparoscopic or robotic procedures. And I just want to touch on the laparoscopic and robotic portion for a second because as we're moving forward in this current era of surgery, laparoscopic and robotic procedures have become more of the norm than they were in the past. As a result, a lot of these procedures are being performed, and we have to figure out how best to provide analgesia for these procedures. And tap blocks has turned out to be a very good way to provide this analgesia because there are multiple ports and they do cause pain. Another indication for this procedure is a C-section. Now, normally when when providing anesthesia for a C-section, one may use neuraxial methods such as a spinal anesthetic or an epidural anesthetic, or in emergent cases, a general anesthetic. There are certain indications for a tap block, and that is if one is unable to give neuraxial opioids for longer pain control, tap block would be of benefit. Or if for some reason analgesia from the spinal or epidural is not complete, a tap block would help. And also in those instances when general anesthesia needs to be used in emergent situations, a tap block can really be a lifesaver because it can provide good pain control. And so we'll go back to the anatomy and discuss that a little bit to help us with how to perform this block effectively. So ideally, all the nerves that we mentioned would be covered by a tap block. There are a couple studies that I'll refer to later that will either support or refute that, but ideally, textbook, these nerves will be covered. And the nerves described, again, to review, are the intercostal, subcostal, ilioinguinal, and iliohypogastric nerves. These nerves enter the space between the internal oblique and the transversus abdominis muscle at some point in their trajectory. As a result, that is why we want to deposit our medication in that plane. We will go into much more detail with pictures of where this plane lies, but anatomically and in terms of knowing where the medication should be deposited, that is why. This allows the blockade of all when the local anesthetic is deposited in that region appropriately, because it will be able to traverse that plane and cover all those nerves. So to get to those nerves and to get to that appropriate area in which to deposit the medication, we have to first know the layers that we need to traverse. So they start with the subq, and then they get to the external oblique, internal oblique, and transversus abdominis. And below all that lies the peritoneal cavity, which is where we do not want to go. And here's an image that would show exactly what layers we have to go through and to get to our endpoint, which is the space in between the internal oblique muscle and the transversus abdominis muscle. Now, I'm going to go over the layers that we have to go through again and again, just as to hammer home what layers are important, which ones are not, and where we need to go. So the multiple layers that need to be traversed again are the main ones: external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle. As you can see, they're color-coded here. The external oblique is the most superficial, followed by the internal oblique, followed by the transversus abdominis. The layers above and below these layers are the subq, most superficially, and the peritoneal cavity, most deep. Where we want to go is right in between number 2 and number 3. In between those two muscles, we want to penetrate that fascial layer, and then separate those two muscles, such that the internal oblique will go superficially and the transversus abdominis muscle will go deep. Again, here's a little bit of a better picture, one with a little bit more focus, provided by the sonosite image that we have here. You can see the subq tissue is most superficial, which would be to the top of the screen, as it is closer to the ultrasound transducer. Then we have the external oblique layer. Then we have the internal oblique layer, the transversus abdominis layer, and then most deep we have the peritoneum. What we want to do with our needle is go through the subq layer, through the external oblique layer, through the internal oblique layer, and we want to stop right above the transversus abdominis layer. The tap block will ideally provide analgesia to the skin, the muscles, and the parietal peritoneum. The ideal coverage, as we've learned in the textbook, is innervated by T7 to L1. Unilateral versus bilateral distribution is based on the deposition of local anesthetic on one side versus both sides, as it makes sense that if we do a tap block on only one side, we will only have coverage on that side. It will not cross over to the other side. Different studies have demonstrated different patterns, as I mentioned earlier. Some studies show T7 to L1 coverage, which is ideally what we want, and others have shown consistent T11 to L1, and some have shown T7 to T10. In those cases, a subcostal approach can be utilized, and that's something we won't discuss in this webinar because we want to just focus on the classical tap block, but that is something to take into account. Again, I want to review the indications as now we have a little better feeling of the anatomy. The indications are an appendectomy, hernia repairs, something that's a little bit more involved, such as a laparotomy, abdominoplasty. Again, for our purposes going forward, I think laparoscopic and robotic procedures will be the norm, and as such, these procedures help. And again, C-sections based on the situations I described earlier. Here is one study, and I have two, and here's another study, and we'll go back to the original. These two studies help us understand that TAP blocks can provide the ideal coverage T7 to L1, or they can provide the T11 to L1. The reason I brought these studies is to show that there is some inconsistencies regarding the actual coverage of the blocks. But the point to take home is that it does provide pain coverage if performed correctly, and that if we need to supplement this because the ideal coverage was not reached, that's something that we can do, and sometimes it is expected. So I do not want anyone to be discouraged if their block, as this study shows, only provides coverage from T10 to 11.1, because there have been studies that have shown that as well. Now, more importantly, how do we perform a successful TAP block? The performance depends on correct deposition of local anesthetic, as I mentioned, in the plane between the internal oblique and the transversus abdominis muscles. Again, I will review the layers to traverse are the skin and subq, any fat, the external oblique muscle, the internal oblique muscle, and then we want to stop in between the internal oblique and the transversus abdominis muscle and deposit our local anesthetic medication. We do not want to go past the transversus abdominis because then we will puncture the peritoneal cavity. Here again is the picture we had earlier with the layers that we want to traverse. The ultrasound-guided TAP block is then performed by placing your patient supine, prepping the area of the abdomen involved in the block. It may be unilateral or bilateral. And if it is bilateral, I suggest prepping all of the abdomen, not one after the other. The specific area is the area between the costal margin and the iliac crest. And you want to, as I mentioned, prep both sides if doing a bilateral block. Place the transducer in the transverse plane and use the anterior axillary line as a guide. Identify your three muscles, and then insert your needle in plane with the ultrasound probe, because that allows you to see the whole length of the needle, allows you to see where you're entering the skin and where the tip of the needle is. Now, one thing I will mention with any ultrasound block, especially with the TAP block, please find where your tip of your needle is, because usually it's a little bit further than you think. In this case, if it's too far, it could be puncturing the peritoneal cavity. So one may also hydrodissect, which means to inject a touch of medication to see where the tip of the needle is. In this block, there is no twitch monitor or no stimulation of the muscle that is used, because this is not a motor nerve that we are stimulating, and as such, hydrodissection will not hurt your block. Going back to the steps, you want to insert the needle in the plane with the ultrasound probe. Use a medial to lateral approach because it increases sterility and is ergonomically more sound. And what do I mean by that? I mean, if we try the lateral to medial approach, we will lose sterility because our hands are very close to the bed. And if a patient is obese, we may not get the angle that we want, and we may not be able to actually see what we're doing. A little bit on the transducer, we can use a linear high frequency transducer with the nerve application setting, and we can use a needle. For a single shot, we want to use a 22 gauge 4-inch blunt needle, and for a catheter, we would most likely need to use a 2E because we need to thread that catheter and we need enough space in that needle. The orientation that we're looking for is the external oblique, internal oblique, and transversus abdominal muscles, and that is the orientation, and that's what's important. If the ultrasound transducer is too medial, the rectus abdominis muscle comes into view. And if encountered, all we need to do is scan laterally until the external oblique aponeurosis disappears and the external oblique muscle is visible. I now have a video that I want to show, and we will start that now. Hi, and now we are going to scan live on the patient, and I'm going to show, number one, how I would use my hands and what position I would place them in for the proper scanning technique, and then we will go on and look at what the actual image would look like on an ultrasound machine. So the first thing is we want to obviously drape the patient. We want to have the abdomen exposed. We don't want to have the limb in that area if possible. Usually this would be done under general anesthesia, so you can kind of manipulate the position as needed. You would prep the area in question. And what we would do then is look for the last rib, which would be right here, and his ASIS, which would be right here. So we have an area about that big with which we can scan and look for the three muscles that we need in order to perform a proper TAT block. So what I'm going to do is I'm going to use my probe, and I'm going to kind of put it right in the middle of that area. And a little bit further away, you can see the ultrasound, which we're going to get to a lot closer, but I can see the three layers of muscle. What I want everyone to focus on is the position of my hand and how I'm holding the probe. As you can see, I'm resting my hand on the patient's body, which will then give me some stability with which I can look at the image, change settings on the ultrasound if need be, as well as to get my needle and local anesthetic if I have help or even if I don't have help. You can scan medial or lateral for a better image. As you can see, again, very slow movements. You can scan cephalad and caudad for a better image. You can see in the background the ultrasound is moving because the image is, I'm traversing the body of the patient to find a better image. Once I find a spot that I like, I'm going to rest my hand here. And what I want to do is come with the needle from the medial aspect. And the reason I want to come with a needle from the medial aspect is that ergonomically this gives me a better angle with which to do the block. If I try to do the block from the lateral aspect, on him he's very thin, so it would be easy, but on other patients who have a lot more abdominal girth, that wouldn't be easy, and you'd be compromising sterility as well by touching the bed. So we would come in from here. Now the other thing that I want to show everybody is that this is one way of holding the probe, and the other way of holding the probe is to actually switch your hands, and I don't want to have my back to the screen, but to kind of get your elbow right here into your body so that you have a little bit more stability as well if the patient was a bigger patient, like someone in OB or whatnot. And the reason we do that again is so that the hand doesn't move, because if I just have my hand like this, it can move and I can lose the image. So with any block, any ultrasound-guided block, stability of your hand, which could then create stability of the image, is very important. So this is the region in which we would place the probe with an image that you have in the background. And now I will switch over and we will just look at the screen while I have the probe in this exact area, and we'll talk about different landmarks. So now I have the second video, as I mentioned in this first video, and we can look at the kind of the imaging a little bit closer and figure out exactly what it is we need to do when trying to perform this block. More importantly, what to look for. And here's the second video. Okay, and now we are going to look at the image on the screen and look at the different layers. So what I'd like to point out is that this would be an ideal image. And as you can see, we have the peritoneum here. We have the transversus abdominis muscle right above it, the internal oblique right above it, the external oblique right above it, and then your subcute tissue and fat. What I want people to focus on here is the order in which I describe the muscle layers. I describe them from bottom up. And the reason I do that is if we use the traditional approach of from top down, in our society today we have many people that have extra layers of subcute tissue, of subcute fat, and as a result, some of the layers can be a little misrepresented when you're looking at the image, and they can appear as if they're muscle layers because of extra fascial layers or, fat that actually looks like a muscle and whatnot. If you work from bottom up, as you can see here, this has to be the peritoneum. And what I usually have the patient do is either take a deep breath if it's a preoperative block while they're awake, or if they're in the OR, I would give them a big breath with the embo bag. Now, there's no question that this is the peritoneum. As you can see, the bowel is moving, there's peristalsis and whatnot. So then what I do is I work up. The muscle layer right above the peritoneum has to be the transversus abdominis muscle. And if that is indeed the case, then right above that has to be the internal oblique muscle. And again, right above that has to be the external oblique muscle. And as we know, what we are trying to do is have a needle come in this trajectory and then get right in between the internal oblique and the transversus abdominis muscle to then infiltrate that area with local anesthetic to give us the analgesia that we are looking for. So what we can do now is I will scan and I will show you what an image would look like if we're in the wrong spot. So if you go to medial, as you can see, the muscle layers come together to form the rectus abdominis muscle right in the middle. And that means you're too medial. So if you see this, you obviously want to go back lateral. And as you can see, the muscle layers are forming to where you get a better image right there. Now if you're too lateral, you'll then see the muscle layers start to trail off as well. And sorry about my machine turning off there. You will see the muscle layers start to trail off. So again, you want to be kind of in this area right here, and this is the image you're looking for. Now this image is the exact same position that I showed you when I was describing the hand placement for the ultrasound probe. Now if I were to go cephalad up towards the patient's head, towards the last rib, this is the image I have. And if I were to go caudad down towards the patient's ASIS, this is the image I have. As you can see, he's very thin, so the image doesn't change much, and in a real patient, it probably would not change that much as well. Now, there is a subcostal approach to the block, but we're not going to describe that here because we want to focus on the traditional tap block, and these are the layers we're looking for. Now, something else I want to point out is, if we were to decrease the depth, because we were not cognizant of how big the patient was, as you can see, this is very confusing. And I'm pretty sure that if I wanted to, I could maybe even confuse someone and let them believe that this layer right here may be the peritoneum, and that may be the transversus abdominis, and that might be the internal oblique, and that might be the external oblique. The reason I point this out is my standard practice is to always increase the depth more than I think it's necessary. As you can see, we do not need this much depth, but there is no question that this is the peritoneum. And so once I know that, then I can decrease the depth to a point where I see everything that I want with the information that I need. I could even decrease the depth a little bit more, but for safety purposes, this is an image I like because I know where the peritoneum is and I know where the 3 layers of muscle are. And so then I know the trajectory I need, and I also know what my margin of safety is with which to not hit the peritoneum. So then when we're talking about the needle, and it's going to come in this way, if we were to stop here, you can hydrodissect, give a couple cc's, to then be able to see, am I too far or am I too close? And if you were here, that means you're a little bit too superficial, so you would have to advance a little bit. And if you went past the layer, and by that I mean in between the internal oblique and the transversus abdominis, you would know because the medication would spread in the muscle and it wouldn't kind of peel the muscle layers away, which is what we're looking for. The reason I'm mentioning hydrodissection is that you need to know where your needle tip is. You don't want to just advance and think that you know where you are because it's very possible that you're in the peritoneum. So that's, again, another little tip that I would advise most people to use is to hydrodissect, which means, again, to inject 1 or 2 cc's of the solution with which you're injecting with to make sure you know where the tip of your needle is. 9 out of 10 times you will find that your tip is a little bit further than where you really want it to be. So getting back to the topic at hand, which is the tap block, we'll review the muscle layers again, and then we'll leave it at that. So again, this is the peritoneum, this is the transversus abdominis, this is the internal oblique, this is the external oblique, and this is your subcutaneous tissue and fat. And we are looking to inject in between the internal oblique and the transversus abdominis in that plane. And at that point, the muscle layers will peel away. And by that I mean the internal oblique will go superficial and the transversus abdominis will be pushed deep. And you will have a pocket of medication right here in that plane. And then that will encapsulate the nerves that we're trying to cover. I hope this was of some assistance. And we'll go back to the lecture material. And I hope that helped describe what it is we are looking for. And I have a third video, and the third video will actually show deposition of the medication in between the 2 layers, such that we get a little bit of an idea of how things are supposed to look. And here's that video. And as you can see, they have the needle in view, which is a good view, and we're trying to get through the layers of muscle. And so they got through the first layer of the muscle, which is the external oblique, and now we are going through the internal oblique, and we're there, and now they are trying to puncture the area that is in between the internal oblique and the transversus abdominis, such that we can deposit the medication and infiltrate the nerves that we need to cover, so that we can have the coverage that we're looking for. And if you look, they're trying to get in that layer, and as you can see, as they deposited the medication, the muscle layer started to peel, and one went superficial and one went deep. And what we're looking for is that type of spread. We're looking for a spread so that the internal oblique peels upward and the transversus abdominis muscle peels downward, and by that I mean deeper. And if we can get a nice pocket of medication in between the two, we will have good coverage. Sometimes what needs to be done is we don't see a great peel, even though we know we're in the right area. And at that point, we need to move the needle or kind of just progress it through that open layer such that it peels a little bit more. So injection of the local anesthetic is obviously very important. The proper technique and placement of the needle will lead to a proper injection. The injection of the local anesthetic needs to provide a hypoechoic fluid pocket between the two muscles we described. And any resistance, as with other regional techniques, is reason to stop that injection. It should inject easily. And speckling indicates an intramuscular injection, as we discussed with the hydrodissection theory. So then we need to either move it cephalad or caudad. It is a high volume block, and as a result, it needs more volume than other blocks, such as other peripheral nerve blocks or other infiltration blocks, but less concentration is required. And as a result, the local anesthetic toxicity dose is still respected, and we are not crossing it. What I use is 60 cc's of the local anesthetic I like, which is 0.25% bupivacaine, and I use, when I say 60 cc's, that's for a bilateral block, so I would use 30 cc's on one side and 30 cc's on the other. It has been described 40 cc's to work, and you can use 0.2% ropivacaine, or we have the new liposomal bupivacaine, so you can use one vial of that diluted to the 40 to 60 cc's that we just described. Now, if we wanted to perform a tap block with a catheter, that is well within something that we can try to achieve here for a longer duration of pain control. And we would do that, as I mentioned, because we want anesthesia that lasts a little bit longer than the single injection. So the technique is very similar, except that we use a TUI needle, as I described much earlier in the lecture, and that's required because we have to thread the catheter. The one thing to keep in mind with a tap block catheter is that while the catheter may be in the exact right position, it may need to be bolused from time to time so as to fill up that pocket with medication, because the catheter will only allow the deposition of medication at whatever rate we choose, but the big pocket of medication will be absorbed and metabolized such that we need to refill that pocket. The catheter is threaded with ultrasound visualization again, and that's what makes this an easier procedure than it was in the past. And you can use a dilute infusion after the initial injection. As I mentioned here, there are a variety of things to use, and we usually run it between 6 and 12 cc's, and it's very variable because, again, there's a large area to cover. Lastly, there are complications of this block, though they are not really seen that much, because it is one of the safest blocks we perform under ultrasound. But proper needle control, complete visualization will add to the safety profile and decrease the amount of complications we can have. Main complications that we see are peritoneal puncture, intraperitoneal injections, and that's very easy to think about because the peritoneum lies right below that transversus abdominis, which is, again, why it is so important to see your needle. Bowel injury, which goes hand in hand. Local anesthetic systemic toxicity, which goes hand in hand with the volume, which is why we described that at length, and liver laceration, which I have really not ever seen, but it is a described complication. I want to say thank you to everyone. I really appreciate your time. I hope you learned something from this lecture and that it's useful in your practice going forward. I would also like to thank Sonoside for the opportunity, and if there's anything else that we need, please feel free to get in touch. Thank you.